Hello, my name is Austin Docherty and I'd like to demonstrate my hip and groin examination in 7.5 minutes with the able assistance of one of my colleagues. The first thing I would do to assess a hip and a groin problem is to check the patient's lumbar and thoracic spine. Obviously, pain can be referred from these areas, so we do a quick assessment looking first of all at the patient's back, and we check for a normal lordosis in the cervical spine, a kyphosis in the thoracic spine, and a lordosis in their lumbar spine. We would then palpate. I won't demonstrate that, but we would check the spinous processes, we check the vertebrae for any evidence of any tenderness anywhere. Next thing that we would assess would be the range of movement or the range of motion that we have in somebody's spine. The major movements that we're concerned with are flexion. Would you mind bending forward and touching your toes? That's fine. Extension. Would you mind going back as far as you can? That's fine. Then we would assess lateral rotation and lateral flexion, and I would normally secure the pelvis. Would you mind sliding this arm down the outside of your leg as far as you can? Thank you. And now the other side. And now if you rotate the top of your body around, thank you, and now to the other side. So we assess flexion, which is normally from it's a lumbar spine movement. Rotation and lateral flexion is thoracic. Following that, once we've assessed the patient's spine, then we would move on to a more specific examination of the hip and pelvis. We'd ask the patient just to lie down for us, if you wouldn't mind. Thank you. And the first thing that we would do is we would inspect. We would look for any wasting, we'd look for any scars, we'd look for any evidence of a hernia. If we suspected a hernia, we'd examine the patient standing up and lying down. We won't show that at the moment. And then once we are happy that we've checked everywhere, we look for muscle wasting, then we would move on to palpation. Certain areas that we need to palpate, we would palpate the anterior superior iliac spine for the insertion of sartorius. We would palpate the anterior inferior iliac spine for the insertion of the rectus muscles. We would palpate the trochanteric bursa over this area for any evidence of trochanteric bursitis. We would palpate over the pubic bones for any evidence of a stress fracture, and more centrally we would palpate over the symphysis pubis for any evidence of osteitis pubis. Once we have palpated, and we would then move on to range of motion. At the hip, there are certain ranges of motion that we are concerned with. The main ranges of motion are flexion, extension, lateral internal rotation, external rotation, abduction and adduction. So to assess for flexion, we would ask the patient just to raise their leg. If you can just bend your knee up for me. And we would assess for a full flexion in this area, and that feels normal. To assess for abduction, we would just hold the patient's ankle and just gently move the leg of the patient laterally. Adduction, we would check in that way. Internal and external rotation, we can check that through just doing a log roll of the patient's leg while in full extension. Or we can assess internal and external rotation by putting the hip into 90 degrees of flexion, and then we can externally rotate or we can internally rotate, so checking for range of movement. We can check extension by having the patient move over onto the tummy, but we'll do that in a few minutes. We can assess the muscle groups by looking at those ranges of movements. We can assess the quadriceps by, could we ask you to do a straight leg raise and keep your leg up and don't let me push that down. Okay, so that assesses the hip flex of the quadriceps. To test for iliopsoas, we would put the hip into 90 degrees of flexion, and then we would ask the patient to bring their leg up towards the tummy, and at the same time we would resist, and that tests for iliopsoas. We can assess for abduction, and abduction is, as we've demonstrated, is the movement outwards, and we would ask the patient to extend the legs out and we would provide resistance. That's going to test the gluteal muscles. To test for the adductor muscles, we would ask the patient to bring their legs together and we would resist that. This will test for any problems with gracilis, adductor magnus or adductor longus. Right, so we've checked those movements, we've checked their internal and their external rotation. Could we get you to lie on your tummy, please? As we mentioned, to assess for any problems with their hamstring, which is concerned with extension of the hip, we get the patient to raise their leg. If you raise your leg up, don't let you push your leg down. That will assess for any hamstring problems. We can test their gluteal strength by getting the patient, if you bend your knee up and just lift your thigh off the bed, keep it up and don't let you push it down. That will test for any gluteal strength or any lack of gluteal strength. Following this, we would then get the patient to turn back onto their tummy. And now we'll do specific tests for clicking hip. There are three sources of a clicking hip. A clicking hip can either be from the iliopsoas, from the IT band, or from the hip joint itself. To assess for an iliopsoas problem, we would get the patient just to flex the hip to 90 degrees and then put your heel onto your opposite leg and gradually bring your foot down towards your other foot. And if we can feel a clicking around this area, that may indicate that the patient has got a clicking hip secondary to an iliopsoas problem. Other causes of a clicking hip include a problem with their IT band. We can assess the IT band by doing an Orbis test, which we did on a previous examination, so we won't demonstrate that. But we can also demonstrate any problems with the IT band by having the patient roll on the side. Would you mind rolling on your side facing the wall for me? And we can put their hip into flexion, and we would gradually just move the hip up and down, feeling for any clicking that may occur over the IT band. That's fine. Finally, the other source of a clicking hip may be from a labral tear. And to test for a labral tear, this will occur at the hip joint itself. The patient normally complains of pain in the groin just over where the actual hip joint is. And to assess for this, we would normally put the patient into flexion, if you just relax, and hold their leg in one hand. With the other hand, we would attempt to put pressure over the acetabulum, and we would move the patient into internal and external rotation, feeling for any click that may indicate a labral tear. To check for a posterior labral tear, we would have the same movement, but we would feel posteriorly over the buttock area to feel for any clicking or any popping. That completes a very brief hip and groin examination.